Cantwell, did you have anything?
I have responses to but I don't know if you wanted to ask questions or if you wanted me to go.
Well, it might be better if you go, because
Sure.
if I see that 56% of the kids who are enrolled in the program haven't seen a dentist, I'm having trouble couching that. And so if there's something that you would like to address to that,
Sure.
please do, and then we can have a fuller conversation about the audit and the program, the budget, and its impacts.
Sure, so I'll just go quickly over the items, and certainly I can follow up if there are questions that are done to me, but we do take seriously the recommendations of the audit. We did agree with 23 of the 24 recommendations. Several of them were areas we were looking at prior to the audit. As was mentioned, the implementation dates of those recommendations vary depending on whether they require system or regulatory changes, but we are developing work plans to implement all of those recommendations. Just a couple of the key areas that we're working on include the increased oversight of our fiscal intermediary, and we have recently received initial drafts of the beneficiary and provider outreach plans, and we are reviewing those. We are also working with our contractor to implement as quickly as possible contracts with mobile dental vans in order to serve underserved areas in particular, as well as going to school sites to provide services. We are working on administrative simplifications that have been recommended by the auditor, with the balance that we need to take into account some of the program integrity issues so that we're not oversimplifying in a way that might increase some fraudulent activity. We are working on the completion of the annual reimbursement rate study with a targeted date of July 1st. And we are, as part of, I mentioned, our waiver renewal, our 1115 waiver renewal, one of the areas we are looking to focus on with the federal funding we're seeking under that waiver is to provide incentives in our dental program to attempt to increase provider participation. A couple of things in terms of the improvements that we're working on. We are working with our Los Angeles County stakeholders and our Medi-Cal managed care plans in Los Angeles. We've been participating in a medical dental collaboration project where the goal is to increase utilization for dental services for kids aged 0 to 6, and it's a targeted campaign of primary care physicians who are seeing kids on the medical side who have not seen a dentist, and ensuring that there is a referral being made to dentists for those kids. In terms of the fee-for-service delivery system, we are implementing the outreach campaign that was contained in last year's budget in terms of a direct mailing to the parents of children who have not had an annual dental visit in the last 12 months. We did do that in February. Over 550,000 letters were mailed. We have seen an increase of about 250 calls a day at our call center since that mailing has occurred, and we are also doing outbound calls to those households who we sent the letters to again make people aware of the importance of early childhood oral health. In addition, we are working with our dental managed care plans in Sacramento and Los Angeles County on the goals laid out by CMS to increase dental utilization by 10 percentage points. The most recent data, which was requested as part of this for fiscal year 13-14, we are seeing in the fee-for-service system 54.5% of kids receiving an annual dental visit, and in dental managed care, it's right around 40%. Obviously, those are not numbers that we like to see. They have come up slightly in recent years, and we are working on these activities to try to increase utilization. I will sort of stop there. Let me see what else there. Oh, in terms of the adult restoration, I know there were some questions about that utilization. It's a little early for data given the May implementation date and the ramp up, but if we look at the period from comparing utilization in December 2013 for adults to December 2014, there's still a lot of data lag that would happen for dates of service through 14, we have seen almost a triple-sized increase in utilization for adults, and we're anticipating another increase in the next several months so that we'd have over 1 million users compared to in December 13, we had 285,000 adults receiving dental services. And for the same comparison period, we have seen an increase of over 300,000 from 1.7 million to 2 million. And the data that we're seeing does align with what we've projected in the budget, and we'll continue to project a ramp up of the expansion of services.
Anything for finance? Anything from the LAO's office? Mr. Carlson, if you afterwards, we'll have some other questions for you.
Please.
But if finance had anything, did you have anything, finance? I'm sorry, LAO's office.
Thank you, Mr. Chair. Just very quickly, in general, with regards to oversight issues and access to care in Medi-Cal, we know that the legislature has been concerned about these issues over the past several years. Broadly, we've recommended that you devote the majority of your oversight to managed care issues, since that's where the majority of benefits and populations are covered. Dental care is the one main exception due to the preponderance of children and adults who've had the benefit partially restored who remain in fee-for-service Denti-Cal. So we just think that broadly within the fee-for-service system, this is the perhaps one main area where you should focus your time and resources on access issues. Thank you.
Agreed. Thank you. Mr. Carlson, we'll have a few questions for you. Mr. Bonta, any questions?
Thank you. For DHCS, and first of all, thank you to the auditor. Appreciate this report and the guidance and observations in it. Want to ask DHCS, what is the department's own process for self-evaluation? And specifically, was this news to you from the auditor's report, or was it something already known? And if the latter, talk to me about the steps that were already in the works being taken, if any, and if this kind of was a sort of a synergy here from the auditor, or if this was new news.
Sure. No, I mean, certainly I think there were likely items that the auditor raised that maybe hadn't been on our radar, but generally the issue of pediatric dental utilization has been something that the department has been focused on over the last several years. In partnership with CMS, we've been setting targets to try to improve our dental utilization, and we were going down the path of looking at mobile dentistry, teledentistry to really get at some of those underserved areas that were noted in terms of, low participation of providers. So I think definitely there were things we were already working on. I think there were other things that, were more highlighted for us that we were able to focus on as a result of the audit. And we are willing and able to continue to work on how do we improve this. It is a struggle that we face, and it is a struggle that other states face as well in terms of these low levels of annual dental visits among Medicaid children. And that's where we're trying to work with our partners at Delta Dental, at the California Dental Association, about how do we make sure that there is information out there about what the benefit is, how people can access it, and the importance of oral health in sort of the impact of overall physical health. And those are the areas that we're focusing on. As I mentioned, part of the waiver renewal that we're looking at generally is focused on our Medi-Cal managed care program. As the LO noted, most of our population is in that, but in terms of our dental provision, it really is a fee-for-service world, and that is really one of the two areas in fee-for-service. We are devoting significant time in our waiver development on how do we look at alternative ways to look at this, how do we look at potential incentive payments for providers to increase participation. One of the things we struggle with Medi-Cal rates in general, and I think specific for dental, again, we have an obligation to implement what's in statute in terms of payment reductions, and we monitor whether there have been downward trends in utilization. We have not seen that, which is one of the reasons why we don't have the administrative authority to lift the reduction that is in place on regarding the 10%. But it's also one of those questions of how much of a rate change, if there was one, would actually impact utilization. We have seen fairly low, consistent utilization of dental services in the Medi-Cal program. As I mentioned, it has gone up as a result, I hope, of our outreach efforts, and those are the things that we want to increase. But one of the challenges, and one of the things we'll be exploring in looking at our waiver renewal and the potential incentives we want to build in there, is how do you target those? And what are the most appropriate ways to do that in order to increase provider participation and not just increase costs generally, but actually increase utilization?
Thank you. There were a lot of observations of areas for improvement in the program, a number of recommendations. How can this subcommittee be most helpful to you in taking the action or discrete set of actions that really make a difference for these children that have not had access and are represented by this very disappointing underutilization rate of 56% in 2013?
I mean, certainly the department and the administration would like to hear ideas about how do we tackle this issue of increasing utilizations. Part of it may be a provider participation issue, but it's clearly something else going on as well. And is it access to after-hours care? Is it access to, like I said, school sites and things like that we're really exploring as ways to have alternative access points for kids, from low-income families who might have a challenge sort of going sort of through the regular process of seeing a dentist. And so those kinds of things you'll also see, I'm sure we'll talk about in a later hearing. We are trying to do some things with respect to what types of providers can provide some of the preventive services, expanding that to the registered dental hygienists as a way, again, to try to expand access. But we do think that one of the core issues is, yes, provider participation is one side of that, but how do we actually get the appropriate outreach and education so that folks are aware of the benefit and know how to access it?
Ms. Kenwell, to your last point, I wanted to, when you were saying how do we increase access and what are the right places in the community, I want to share with you just my personal experience. Some years ago, when I was on the school board, we built a state-of-the-art dental clinic in an elementary school. It was in a school that has the highest rates of poverty, some of the highest issues around health. And we were clear that there are obvious benefit to young people who don't see a dentist, but there were also impacts on education. Kids can't learn when they're in pain, and so I would certainly encourage that be one of the outreach locations that be considered. I would like to ask you, what's the timeline, though? You mentioned that there would be mobile clinics. What's the timeline for the rollout of the mobile clinics?
Sure. So we are targeting with our Delta Dental contractors to have at least some of those contracts in place by the end of the second quarter of this calendar year. So by June, to have at least some of those contracts in place. I don't know the exact sort of number. I can certainly follow up in terms of what are we looking at in terms of scope and availability of those mobile providers. But we are targeting the end of June, essentially, at the latest, to have at least some of that going on.
We'd urge urgency, and we would like to have that information about how many clinics, how many communities, because if I read this right, that there are 16 counties that do not have a provider. I'm very concerned about the impact that has for children and families. Thank you. Ms. Carlson, question about the audit. I appreciate your report because with data, we can use that as a tool. I'd like to know what the audit, if any, findings pointed to that would be opportunities for us here. You referenced comparison to other states and how far we lag in comparison to other states. There was a question about what should the rate increase be to help us increase our utilization. Did the audit, lift up or highlight any rate increase or what the percentage should be to at least move us in the right direction?
We didn't calculate as part of our audit where what it should be. Our concern on the utilization rate was the absence of a measure in place at DHCS about a criteria or a benchmark of where they wanted to be. That's why we had to reach out to others. We reached out for data to other states, some nationwide data, so that we had some way of comparing just what the status was. And that was the same thing with provider participation. As I mentioned in my testimony, we used a ratio of 1 to 2,000. That's one provider to 2,000 beneficiaries. That's not a ratio that DHCS uses on the fee-for-service side for dental. We actually borrowed that from the managed care side, and we also noted that healthcare services used that same 1 in 2,000 ratio when it was monitoring the transition of the Healthy Families program into the Medi-Cal program. So our concern there was more the absence of any measures, and we used measures that we found in the environment, if you will, to draw the comparisons. That was one of our first recommendations we made in the report was healthcare services come up with that benchmark, come up with that criteria so that you can do that measuring and then continue to monitor the results of that measurement over time.
Did the audit in any way engage providers to ask them? I'm sure if you ask we're going to hear from some providers today, I know, who are going to say, I wouldn't touch it at all at this level, but if it was this, did you get that kind of feedback in the audit?
We didn't directly contact providers. What we did is we relied on several academic studies, white papers, other types of documents, basically research that other folks had already done and had already made available to the general public. And we took an almost academic approach where we looked at what others had done before us and we summarized that. And that's where we got the idea about low provider participation contributing to low beneficiary utilization. And then similarly, those same studies, those same reports also said that one of the leading factors for low provider participation was low reimbursement rates, and that's why we took a look again at how California's reimbursement rates stacked up against those both nationwide, regional rates, and for 3 other states that we selected. Reason why we selected those 3 other states, according to a study, they were amongst the 3 highest had the 3 highest rates of utilization in the nation.
Highest rates, highest utilization, lowest rate, lowest utilization. Seems an obvious connection. Having said that, we'll stick with the data. I see here that rates haven't increased since 2000. Is that right?
That's what we found, yes.
And so is there a way to do a comparison of what utilization rates were at that time and then what the drop-off, presumably that there's been a drop-off since 2000 if those rates have stayed the same to now?
I'd have to defer to healthcare services about whether that data was even available. If it is available, clearly we can take a look at it and see what we can do with it.
Can we access that data?
I'd have to check about going back that far. One of the things I would note is we actually saw an increase in utilization after the implementation of the payment reduction. So while I agree that there is a connection between rates and utilization, it's not the only connection.
I agree it's not the only connection. I guess I would say I'm making an assumption that most people are like me, maybe not as bad as me. I don't want to go to a dentist unless I have to. And so I don't want there to be any barrier for a thing that already carries whatever disincentive, I guess, people would experience for not going. And so I'm not challenging your assumption about rates, but it just seems to me that it's obvious we got to remove all barriers. So we'd like to get that data, please. You mentioned, sir, the lack of compliance in the audit about Delta Dental. In the contract with Delta Dental, you both did. Could you just say a little bit of exactly what the lack of service that was provided was, just so we have clarity there?
Sure. I'm going to actually refer you to our report. I understand that copies of our report were handed out earlier. On page 48, we have figure 7, which talks about 8 provisions related to provider outreach that Delta is supposed to conduct. And we took a look at the first 5 of those provisions, and what we found is that for provisions 1, 2, and 3, we found no evidence that healthcare services was doing it. Now, healthcare services and my office, there's a little bit of disagreement, which we talk about in our report. They believe they have. We believe they haven't. For example, let's pick Item 2 there, contract with one or more entities to provide additional dental services in either fixed facilities through the use of portable dental equipment or, such as mobile clinics in underserved areas. We asked for copies of contracts. We were provided with a copy of work that was in progress, but it was not yet completed. Now, this contract has been in place since 2004, and we're looking at provisions in during our audit work during 2014, we figured there was enough time for the provision to be enacted.
Very good. Ms. Cantwell talked about the work that the department is doing to expedite these recommendations, and I believe that. And so I will just say that this is of high interest to this committee, and we'd like to have that information come forward shortly. Keep us up to date. My last question on this subject is about dental services for adults with developmental disabilities, who I understand use Denti-Cal. Is there still any usage of Denti-Cal by adults with developmental disabilities?
Absolutely. So, in addition to that we've expanded dental services to all adults now in terms of preventive services. That population in particular has had access to needed dental services in facility settings, and so that has been an ongoing area that we've been looking at and making sure that those services are being provided. Are
there any limitations, and I ask that knowing that many folks who have a developmental disability and adults who don't often have to, are not able to be awake during the procedure. Are there any limitations in particular for consumers with developmental disabilities in Denti-Cal?
I'm sure that there are probably some. Certainly, the area we've seen the most challenge in terms of sedation dentistry has actually been with children and not with adults. We haven't seen as many challenges in accessing that service, but it is something we're looking at in terms of individuals who need anesthesia to receive dental services and making sure that there is sufficient locations, generally hospital-based locations, that provide that service.
So no limits on sedation per se.
It needs to be medically necessary.
Got it.
Obviously, yeah.
Very good. Okay, let's hear from the speakers. They've been patiently waiting. 1 minute each, please. Thank you.
Good afternoon. My name is Dr. Anthony Mock, and I'm the clinic director at Highland Hospital Dental Clinic in Oakland, chief of general dentistry and special needs coordinator at Alameda Health System. Highland Hospital is a safety net for medical and dental services in Alameda County. Since 2009, when the state eliminated adult dental services, in Medi-Cal, the number of urgent or emergency patient visits in the hospital emergency room and our emergency drop-in clinic has almost doubled. Moreover, the number of patients from outside Alameda County compared to patients from Alameda County has increased threefold. California's extremely low reimbursement rates have created a situation where patients in need of emergency care who have not been able to find a Denti-Cal provider are willing to travel many miles to see us at Highland Hospital for treatment. As state's audits points out, the majority of counties in California have an insufficient number of dental providers, and Highland Hospital is seeing the results firsthand. What's frustrating about the situation is that dental disease is so easily preventable. A patient can get basic preventive care, and it costs pennies to provide preventive care compared to emergency care. The state cuts Denti-Cal reimbursement rates based on the assumption that the cuts would not affect patient access to care. I see firsthand every day that this assumption is simply not correct. This is not a functional program right now. Patients should not have to be traveling across counties to get emergency dental care because they can't get basic preventive care anywhere in their own county. The state needs a reimbursement rate structure that is sustainable for providers that allows patients to get real access to dental care. Thank you.
Thank you. Next speaker, please.
Hi, my name is Alicia Hall, and I live in Sheridan. I have a 6-year-old son named Sean who is enrolled in Medi-Cal. He's developmentally delayed and has a rare syndrome called Rubinstein-Tabby syndrome. This condition means that he has to get dental care, even the most basic care, in a hospital under general anesthesia. One of the issues that comes along with this syndrome is small respiratory airways, which makes general anesthesia treatment more complicated. So his treatment has to be handled very carefully in a hospital setting. Sean was due for an appointment this month, but I was informed that because of the extremely low Denti-Cal reimbursement rates, the hospital here in Sacramento, where he has been receiving care for the past 3 years, had to drastically cut back the availability of dental care. He is now on a waiting list, and I have no idea when he's going to be able to get an appointment next. I can't stress enough the importance of Sean having timely access to dental care that he needs, and I understand that fewer and fewer hospitals statewide are able to provide this care any longer. So many other patients around the state are facing the same situation. I'm trying to do the right thing. I'm trying to get my son regular dental care, but we have no place to go right now. The Medi-Cal program is an empty promise if it doesn't have enough funding to ensure patients like my son can get the care they need. Coverage doesn't help us if we can't get actual dental care. Please do your part to fix this problem and provide more funding for Medi-Cal dental services this year. We cannot wait another year. I want my son to be as healthy as possible, and that requires regular treatment. Please act this year. Thank you.
Thank you. Is it okay if one of my staff who is in this room follows up with you? Thank you so much for what you shared today. Thank you.
Thank you.
Good afternoon, Mr. Chairman and members. My name is Jacob V. Hill. I'm with the Children's Partnership, a children's advocacy organization. And I really want to echo the statements of my colleagues regarding the critical importance of preventive dental care for children and the preventable nature of chronic dental disease, which we know is the most common disease among children. We thank you for including the recent audit of Denti-Cal on today's agenda. In our view, this is one of the singular most important reports that's been completed in recent years, and it merits continued and serious attention by this committee. The Children's Partnership supports all the recommendations in the audit report, but I would like to highlight 3 particular recommendations that, with your leadership, we believe that we have the opportunity to ensure that the department can really move forward on some of these issues. The first would be the development of an accurate measure of provider adequacy in the Denti-Cal program. And this, we believe, should include the number of available providers who treat certain subpopulations of children who have especially limited access to care, particularly young children and children with special health care needs. It should include all geographic areas of the state in smaller units than counties, and the number of current and new Medi-Cal enrolled patients a provider treats, as well as the time it takes for families to get an appointment and receive care. And we believe that by looking at these and other measures that we can better target efforts to close the dental care gap. Secondly, increasing the number of Denti-Cal providers that serve children by targeting raised reimbursement rates to reasonable levels, particularly for providers who serve young children. And thirdly, investing in the virtual dental home, which the law was recently signed by the governor, that brings dental care to children in schools and Head Start sites. And this addresses the barrier that families face in accessing care through the traditional office-based system. So the Children's Partnership looks forward to working with the committee and the department to implement these and the other recommendations included in the audit report.
Thank you.
Thank you.
Good afternoon, Erin Mercer-Niehaus with the United Ways of California. I'd like to echo the comments our coalition partner just made with regard to supporting the recommendations identified in the state auditor's report. We support improvements to monitoring of pediatric dental care to improve pediatric utilization numbers. Dental care for children can mean a positive or a really negative start to life. And in addition to the health concerns, we know that dental pain keeps kids from school and learning, and thereby they fall behind. So we must ensure kids have access to dental care starting at age 1 to mitigate negative long-term impacts later on in life. Thank you.
Thank you.
Thank you, Mr. Chair and members. Alex Hawthorne. I'm here on behalf of the California Dental Association. We'd first like to thank the work of the audit staff and the committee for highlighting the challenges and problems in the Denti-Cal system. Mr. Chair, as you mentioned, it's very concerning when less than half of the children that are eligible for care are actually receiving any. So very briefly, just 3 points we wanted to bring up. First, we would like to see a better system of monitoring access to timely care. The state has to be able to understand the true capacity of the dental care system so it can make sure patients are getting the care they need. And second, it's clear from the report and the research and from CDA's work with its membership that the rates paid to providers have a tremendous impact on their ability to either join the Denti-Cal network or see more patients in the Denti-Cal system. Rates that are 35% of the national average have not been increased since 2001 and were cut in 2013 cannot sustain a dental care network, which the audit demonstrated. And finally, CDA is encouraging the state to develop a mechanism to measure capacity within the Denti-Cal system and adjust the rates to providers to make sure it has enough capacity to meet obligations to the millions of Californians who are enrolled. So we look forward to working with the administration and this committee to begin addressing the serious issues. Thank you.
Thank you.
Hello again, Janice Allen, Children's Defense Fund of California. I'm representing the Children's Health Coalition, which also includes the California Coverage and Health Initiatives, PICO, United Ways, the Children's Partnership, and Children Now. We continue to be concerned about access for children in Denti-Cal, and we're hoping to see big changes this year, and we align our remarks with the Children's Partnership and the United Ways. Thank you.
Thank you.
Good afternoon, Chair Thurman and committee members. My name is Eleanor Mattern, and I'm the Deputy Director at the First Five Association. I want to thank you for your attention to the serious challenges faced by young children in the Denti-Cal program. Over the past decade, county commissions have invested approximately $25 million a year in oral health services serving children 5 and under, reaching around 150,000 children a year. First Five commissions have built clinics, trained pediatric dentists, and educated parents on the importance of bringing their children to the dentist. But the single greatest barrier, as we know, to good oral health in California is the lack of dentists willing and able to serve young children. So just very briefly, an example from Orange County. First Five is working to sustain this system in Orange County, where the Commission has invested $15 million over the last 10 years. Orange County now has the highest rate of Denti-Cal visits by young children in the state, in large part because of the First Five funded Healthy Smiles program. However, even with this investment, there is only one dentist for every 4,900 children, 0 to 5. And at present, out of the 546 active dentists on the Denti-Cal roster, only 4 dentists offer sedation services to children. The First Fives appreciate your interest in the issue and would welcome any opportunity to partner with the state to improve the dental services landscape. Thank you.
Thank you.
Hi, I'm Sarah Benjamin. I'm from Children Now. Mr. Chairman, to your point about programs in schools, California had a prevention program in schools up until 2009. The California Children's Dental Disease Prevention Program, which was defunded in 2009. Children Now supports the restoration of funding for this program because we believe children are in schools, need to be seen in schools, and it's a great synergy to work with the Medi-Cal dental program, which clearly isn't reaching all kids. We would also like more transparency in how DHCS is going to implement the corrective action plans. We'd like to suggest that the Medi-Cal Children's Health Advisory Panel be involved in tracking and monitoring the implementation of these plans. Based on our reading, there are 3 of the corrective action plans that should have already, well, actually one is slotted to be completed by March 1st, but as the gentleman from the auditor's office said, one has been completed. That was for January 1st. I'm hoping there's one for February 1st, which we're also hoping is completed. So just more transparency to know what's going on with those. Thank you.
Thank you.